Okay, thank you, Andrea. Good morning. And in this speech, the content of this speech refers to a sub-project of SPOC 2, which deals with predictive and preventive medicine in different clinical settings. And we are in the clinical settings of predictive medicine for response to therapy, in particular in the area of cardiovascular disease. And the specific title of the project is Tailored Treatment in Patients with Atherosclerotic Cardiovascular Disease, Searching for Predictive Markers of Bleeding and Thrombotic Complication on Antithrombotic therapies. We think there is an urgent clinical need in order to improve the efficacy of antithrombotic therapies, so the possibility of reducing thrombotic complication, and to the possibility to enhance their safety, and so by reducing bleeding events, bleeding complication. First of all, I want to remind you that we are talking about the most the disease which are the leading cause of morbidity and mortality in the Western countries. And we have just mentioned two keywords. The first is atherosclerosis, and the second is thrombosis. How do they connect? We know in a modern view of atherosclerosis, we have moved from the idea of a passive accumulation of cholesterol in the vessel wall towards a more complex picture in which we know that atherosclerosis is a chronic inflammatory disease in which the early events are caused by the entrance of leukocytes into the vessel wall, and these leukocytes, the entrance of these leukocytes is mediated by the exposition of a specific receptor by the endothelial damage. And the endothelium is damaged by the well-known risk factors such as smoking, hypertension, diabetes, and also genetic predisposition. And therefore, after the entrance of leukocytes into the vessel wall, the entrance is followed by the progression of atheroma as leukocytes emit LDL cholesterol. They transform themselves from monocytes into macrophage, into the foam cells, which are the stigma, the sign of lipid core in the atherosclerotic plaque. But the late events, which are those that are directly associated with the clinical manifestation, are caused by the complication of this atherosclerotic plaque. The rupture or the erosion of the plaque is followed by the activation of and aggregation, first of all, of platelets, and then by the activation of hemostasis with the formation of fibrin. And so we have the formation of a thrombus. And if this occurs in the coronary vessels, the clinical consequences are acute coronary syndromes. First of all, acute myocardial infarction. If this occurs in the cerebral vessels, the clinical consequence is ischemic stroke. And if this occurs in the peripheral vessels, the clinical consequence is acute ischemia and peripheral artery disease. And so we have just mentioned the more frequent disease affecting our population. And here you can see the complex. This cartoon tries to show you the complex interaction between cells and soluble factors in the atherosclerotic process. And so we know, we can say that atherosclerosis is a long process that begins several years before clinical manifestation. But when we have the clinical manifestation, we have the same event, which is the formation of a thrombus. And that is why we use, the main drugs we use in this disease are antithrombotic therapies, antiplatelet or anticoagulant therapy directed against the platelet function and clotting activation. And so we can agree with this sentence for men and women lives with atherosclerosis but dies from thrombosis. And in this area, I think it is very important to introduce the concept of precision and personalized medicine, because we use these antithrombotic therapies, both antiplatelets and anticoagulants. Nowadays, we use these in a model one size fits all for all disease, for all patients. And we think there is a large space for improving their safety and their efficacy using a model of precision medicine. And with this focus, with this aim, we have chosen to study a subgroup of patients which are at particularly high risk for both thrombotic and bleeding complication, which are patients with concomitant acute coronary syndromes, myocardial infarction, and atrial fibrillation. This is a population not so rare, as about 20% of patients with atrial fibrillation has concomitant coronary artery disease, and on the other end, about 10% of patients with coronary artery disease has a history of atrial fibrillation. And nowadays, in these patients, we use a triple antithrombotic therapy by adding the dual antiplatelet that we use for acute coronary syndromes with oral anticoagulant that we use for atrial fibrillation. And so the results is that by using this triple antithrombotic therapy, we try to minimize ischemic risk, but doing this, we maximize bleeding risk. And so we have a perfect model in order to verify the possibility of introduce a precision medicine in this context, in which the clinical problem is the bleeding. We have organized a register including these patients in the framework of this PNRR project with patients follow-up at 1, 3, 6, and 12 months. And before showing you the first results of this register, I have to remind you some previous results of our research group, which have identified two laboratory phenotypes, so two markers, which identify, as you can see, high platelet reactivity on antiplatelet therapy. So some patients show a normal platelet function, even if on antiplatelet drugs. And we can measure these, and we have named these high platelet reactivity by ADP on clopidogrel, or high platelet reactivity by arachidonic acid on aspirin. And we have just demonstrated that this phenotype is associated with a higher incidence, significantly higher incidence of mortality after myocardial infarction, and that these phenotypes maintains its prognostic negative impact at 2 years of follow-up. which are the cause of this phenotype? We have genetic condition. For example, we know that clopidogrel, which is one of the main used antiplatelet drugs after aspirin, is a prodrug that needs to be converted into the active drug by liver. And we know that some patients carrying genetic variants in gene codings for cytochrome P2C19 have a reduced possibility of this conversion, and so they have a less response to these drugs. But there are also several acquired factors affecting our response to platelets, to antiplatelet drugs. For example, persistent conditions such as diabetes, advanced age, and female patients have platelets, larger platelets, more reactive platelets, and so females have a less response to the standard dosage of antiplatelets. The same for diabetic patients, for example. And there are also many other transient risk factors able to affect our response to standard dosage of antiplatelet drugs. For example, we know that in the acute phase of an acute myocardial infarction, there is in the acute phase of acute myocardial infarction, there is a high platelet turnover, and bone marrow releases into circulation more larger and more reactive platelets, so-called reticulated platelets, and these platelets have a less response to the standard dosage of antiplatelet treatment. And only a moment, I see on my desk that, okay, I can go to the right slide. Okay. So, sorry for this slide, but returning with this concept to our register, I can show you the first results on the first patients enrolled. We have enrolled about 150 patients. That's a great number with the concomitant disease. I remind you, acute myocardial infarction plus atrial fibrillation, and we have demonstrated, I tell you this because you can see this, that at 1 year of follow-up, these patients have a significant higher risk of bleeding complication with on a triple antithrombotic therapy with respect to a dual antithrombotic therapy, but as expected. But unexpectedly, they have also a higher risk of thrombotic complication. And if we go and evaluate the platelet function testing, that phenotype, that biomarker of response to therapy named platelet reactivity, platelet function on antiplatelet therapy, we have demonstrated that evaluating this phenotype by a genetic assay, we can identify patients at higher risk of thrombotic complication at 3 months of follow-up. And if we measure this biomarker by a platelet function testing, we can identify patients at higher risk of thrombotic complication both early at 3 months of follow-up and at 12 months of follow-up. So we strongly believe that these data demonstrate a pivotal role of platelet function testing practice in guiding antithrombotic strategy, and we strongly believe that these markers can be used tomorrow in our clinical practice. And our work is in progress. We are evaluating our biomarkers, not only in the platelet function, but also in the response to anticoagulant therapy. And we are working in other conditions, such as patients with cerebrovascular disease and peripheral artery disease. And so, in conclusion, where are we going? Better yet, where are we already in the area of cardiovascular disease? We are just in the era of precision medicine. We have demonstrated that it's possible a tailored antithrombotic treatment based on clinical procedural characteristics and using also biomarkers of response to therapy in order to administer the right drug to the right patients at the right time. Thank you for your attention.